Good afternoon. Good morning. It's a little daunting to be here. Usually when I'm called to speak, I'm speaking around homelessness to people who don't know anything about it. So it's really easy just to talk off the cuff from our hearts, from our experiences. So what do you say to 850 people who are doing the same exact work that you do? And not only the same exact work, but much of what I've learned here, I've learned right here in this room at these conferences from many of you who are sitting here, who have taken me under your wings over the years and helped me to learn. We've all learned through experiences, through trials and fires. We found out what works, what doesn't work. We share our experiences, and it's really humbling and honoring to be here. John spoke about Susan, and I remember the very first time I met Susan. I was a living counselor at a rescue mission, and part of my job was to get the guys ready to see the doctor, who was actually a physician's assistant. And Susan came to visit the work, and I don't know why, but I asked her for her business card. And from that business card, I later went to graduate school for public health, and I said, I want to interview you. And so I interviewed her, I wrote a paper, and then later I did my internship with Susan. I was really privileged that for the last 16 years of her life, that she took me under her wing, she mentored me. And I have to confess, it's a little ironic that I'm here giving the policy address because I was a slow convert to really seeing the importance of policy in our work. And I remember she would send me out to coalitions, and I would come back. I liked the policy, but I hated the politics, with people going different factions. And she said, but you can't do policy without politics. You have to understand that. And I have to say that many of the positions that I've come to slowly, but through persistent work and being exposed to the great work of the council. Jeff Singer, the longtime leader of the policy committee, listening to him over and over, to John Lozier, to many. So I'm going to start with my thesis, which is that only policy work can end homelessness as we know it. Now, we here represent many different disciplines. Some of us are social workers. We represent nursing, medicine, outreach, health education, housing providers, policy work, dentistry, research, law. Some of us are clinicians. Some of us are managers and administrators. And some of us are government officials. And I want to approach this next few minutes from the lens of my discipline, public health. And since public health is focused on the group, the population, and that's one way it differs from the clinical disciplines where you focus on the individual resident or patient or client in front of you. Public health is focused on the health of the population. And since we're talking about policy work, public policy work, I think that's a good lens to focus on for a few minutes. Now, in truth, when we bring our different perspectives, our different trainings, our different disciplines to our common work, the overlap is tremendous. The overlap is greater than the differences. But I do want to focus from a public health perspective just for a few minutes around homelessness and the effects of homelessness. Now, when I address, usually as a college student, undergraduate or graduate, I usually begin by asking them, what are the causes? I usually say, why are people homeless? And usually the answers I will get will be, well, someone has mental illness, they have substance abuse, they can't afford their apartment, they don't have a good job, they didn't finish school, they have a criminal record. And as I listen and we jot them down, I then turn to them and say, you focused almost all of your answers were on the weaknesses of the individual. There's a whole nother way to look at it. Instead of saying someone is homeless because they have mental illness, we can say we have an inadequately funded mental health system, that we have inadequately funded substance abuse systems, that Our educational system does not prepare someone to compete in the marketplace. Certainly there's a great disparity in the quality of education between regions of the country and even within cities, between public education and private education. Sometimes the difference is scandalous. But we focus on the weaknesses of the individual instead of the weaknesses of society. One of the tools of public health is we look at the health of a population and we use several different measures. One of them is mortality rate. One of them is age-adjusted mortality rate, which is important because over, the mortality rate of each one of us is really very, very, very close to 100%. So age-adjusted mortality rate is a tool you use to say, well, for a given age, what is the probability of someone dying? And so we adjust the mortality for rate. We look at the morbidity rate. What is the chance that someone's going to get sick? What is the chance someone's going to get sick from a particular disease? And then we compare that. We look at what is the excess morbidity or the excess mortality, saying if everyone was as healthy as the healthiest or as the average, among the sickest, how much sicker are they? The excess mortality, the excess morbidity. And another tool is the years of life lost. Now, when you look at those measures, for every single one of them, you see that homelessness or homeless people have much higher rates of illness, of morbidity, of loss of functionality, of years of life lost. Jim O'Connell's done great work in looking and showing the excess mortality of homelessness that homelessness causes, the rates and the young ages at which people die on the streets. Another article in the International Journal of Epidemiology said that the mortality rate caused by homelessness is 3.5 times that of someone who is housed. So someone age 50 living on the streets or in a shelter will die, has a 3.5 times greater chance of dying than someone who is housed. Now, when we look at the effects of homelessness, we see these great negative consequences. Now, another tool of public health is to look at risks. The basic premise, and we know that not all risks for disease or conditions is spread out equally. So sometimes when we're doing advocacy work, and we will say, and I hear people say this on the subway when they're collecting money for a cause, they'll say that, homelessness can happen to anyone, or we're all one paycheck away from being homeless. And while that could be true in a general sense, that could be true for many individuals, and certainly we have seen from natural disasters such as Hurricane Sandy in the Northeast, which affected many states, we saw many people who just became homeless in the blink of an eye. Some of our staff members lost their homes and were displaced for long periods of time. And many people in New York City and in other states have not yet returned. Those communities are devastated. But not just by natural disasters, but when we talk about social disasters, and there's no other term that we can really describe modern-day homelessness except as a social disaster, those risks are not spread out equally. Some of the risk factors that increase the chance that someone will be homeless is whether they have a criminal record, whether they have a foster care history, whether they have mental illness, whether they are living in a distressed neighborhood or even in a distressed building. In New York, Roderick Wallace did some work looking at the city policy in the 1970s called Planned Shrinkage, where they felt certain neighborhoods were going to expand too quickly. So they purposely withdrew some of the city services, sanitation, police, fire. And what happened was those neighborhoods became gutted and became huge drivers of homelessness as the buildings were abandoned. Low educational status, we see, is a risk factor. Race is a risk factor. Susan Nybacher was one of the first people I heard over 20 years ago continuously address race as a factor and for homelessness. And wherever we go in this country, no matter what region, we will see that racial and ethnic minorities are overrepresented in the homeless population. For many years, the church that my family grew up in had two large congregations. One was in the evening, which was mostly, it started as a homeless outreach, and that's the one that we started attending, my wife and my 3 children. And then in the morning congregation, it was mostly young urban professionals, stockbrokers, and we would go to both services. And one day my 8-year-old son said, "Dad, I noticed in the morning service, more people are white. In the evening service, most people are black and Latino." I said, "That's a good observation." I said, "Why do you think that is?" He said, well, black people were slaves and were discriminated against for a long period of time. I said, "There you go, son of an epidemiologist. There you go." But race is a factor that we cannot ignore. Can I have the first slide? One of the factors, another tool in public health is an emerging concept called syndemics, which basically says that when we're looking at epidemics, some epidemics cannot be looked at separately because they do not exist in isolation. And what the key test case, the most prominent example of syndemics is what's called SAVA, substance abuse, violence, and AIDS. Looking at how those epidemics feed off of each other. Where there's substance abuse, there's often violence, there's often AIDS, how they are all interrelated, and they have a multiplicative effect. Homelessness is a syndemic. There is no health condition, there is no social condition that is not exacerbated by homelessness. If you are a clinician, you know that there is not one disease that you can treat easier or as easily with someone who is homeless than someone who is housed. Homelessness causes disease, and it makes it harder to treat. And when we look at the other epidemics that touch upon homelessness, we have to see that homelessness itself is a public health risk. It's a personal health risk. It is a public health disaster. Next slide. Oh, I have the, yes, thank you. When we contrast the situation, we look at what is the federal government's goals. The Public Health Service, the Health and Human Service laid out their goals for our society in Healthy People 2020. Now, isn't this a great vision for a country? It says a society, the overarching vision for Healthy People 2020 is a vision in which all people, all, live long, healthy lives. That's public health at its very best. That's social work at its very best. Medicine at its very best. A vision in which a society in which all people live long, healthy lives. Next slide, please. And it has 4 overarching goals that we would to attain a high quality, longer lives free of preventable disease, disability, injury, and premature death. To achieve health equity, and limit disparities, and improve the health of all groups. Now just think of how homelessness makes each of these goals difficult to achieve. To attain a high quality, longer lives, we know that homelessness kills, free of preventable disease. So many diseases that homeless people have are caused by their homeless state. Disability, injury, and premature death. Homelessness is the opposite. It leads to the opposite of health equity. It creates disparities and exacerbates health disparities instead of eliminating it. It doesn't improve the health of any group that is homeless. Next slide, please. The third and fourth overarching goals are to create social and physical environments that promote good health for all. One of the key advances in Healthy People 2020 over Healthy People 2000 and 2010 is that they focus a lot on social determinants of health. They talk about housing, the importance of good, stable housing to assure health. And the last one is to promote quality of life, healthy development, and healthy behaviors across all life stages. Now, we see that there's a huge disparity between the vision and the reality. Homelessness makes achieving that vision impossible.